Okay, we'll go ahead and get started. Call the meeting to order, and we'll go and approve the minutes from the February meeting.
I'll move the approval of the minutes. Second.
First and a second, all in favor?
Aye.
Opposed? Same sign. Motion carries. Next, Dr. Devine will do the medical staff meeting summary.
Okay, there were two of them for the last 2 months. First one's the March 11th. Dr. LaRose has retired, so we no longer have a provider for orthopedic sports medicine. So Dr. Bays will still do knees on a case-by-case basis. Dr. Shu will still do hands on a case-by-case basis, but we're also looking at trying to get more coverage from MD West 1, which now has an office in Council Bluffs as well, and they are excellent.
Can I ask a question about that? Will that be
Yeah.
weird with those two different sets of
Yeah.
clinics going on at the same place?
They will.
Okay. Will the other ones pull out
The-
probably then, or where are we?
You mean the other Miller group?
Orthopedic set of individuals?
Shu and
Shu will be here long-term, and we have a contract directly with Shu, and we have a contract directly with Dr. Bays.
Okay.
So
But I
they're
mean,
not going to be here
they-
on the same day,
Okay.
but they will be working with both the MD West 1 group as well as those two other.
I didn't know if that was any
Individual
special consideration for those people then when you're negotiating those contracts. I didn't know if that was something.
No,
Okay.
I think we're in a good position. They're not even going to be here on the same day, so.
excellent.
Sorry.
No, you're fine. We have a new perioperative nurse manager. Dr. Garden also came as our general surgeon during this time frame. The ACO is going to have a name change. They'll be called Wellvana, which really doesn't matter. We're still doing the same quality measures, so. Our dietitian is out on maternity leave, so all referrals will be when she gets back. If we need something in the interim, the Atlantic dietitian has agreed to help us out. Nicole and Michelle Monson are visiting staff at the Manning Hospital in regards to Dr. Kelly Anderson having an outreach OB clinic there. We had initial appointment of privileges and reappointments. And then we met with Joe Mott from MI Medics. That's basically for skin substitutes for people who have large wounds that are hard to heal. Then we have a new allergy provider, and there's some new protocols for immunotherapy to be done here, and those needed to be approved. And that was our March meeting. Then April, we had the measures, our ACO and their results. We are switching in the ER from TPA to TNK for people with acute ischemic stroke. Same contraindications. It's a little cleaner drug, and it is the one being used by university at this time. Tina from Home Health and Public Health said that there were 500, 600 cases of measles in Texas. It's up to 800. It was supposed to have been eliminated in 2000, but now it's back. The closest are in Minnesota and Kansas, but we do have 25 states now involved. Anyone born before 1957 should have native immunity. If you've had at least one dose of the MMR vaccine, you're considered to be protected. The other concern is that some of these individuals are using vitamin A to try to prevent measles, and vitamin A has a toxicity, so we need to be on the alert for that as well. Dr. William Rizik spoke about his practice in Atlantic. He is a general and bariatric surgeon. He used to work in Sioux City. He does a lot of sleeve gastrectomies and is hoping on establishing the practice there and would like our referrals. They are a same-day surgery, about 45 minutes, and are indicated for those with a BMI greater than 35. We do have a lot of prep for that. You have to meet with a dietitian. You have to make sure that you are going to be compliant with medications and with vitamins and everything else with it. So there's quite a bit of workup before, and then there's lab work afterward to make sure there's no vitamin deficiencies. So we have hired Erin Selma as our new provider for the Erling Clinic. She is a local and it's wonderful. She'll also cover one weekend a month in the Quick Care Clinic. And Nicole will continue to cover one weekend in the Quick Care Clinic. And then continuing the discussions with Manning Hospital, they just basically looking for a half-day per month coverage right now. Then we had, again, the initial appointments, reappointments, and voluntary withdrawals, and those were all reviewed, and no concerns were noted. And I think everything else is Christie. Oh, epic upgrade. Says refer to your tip sheets. It's been a little bit adventurous. We then had 2 videos from our wellness portal on diversity and bias, and then adjourned the meeting.
Great. Any questions for Dr. Devine? Great. Thank you. We'll go ahead and move towards the quality improvement report by Laura.
Okay, 17 departments reported at the March 19th QI meeting, and I'll just go over a few of those highlights. Behavioral health is monitoring no-show rates and care coordination with substance abuse documentation, which was at 100% for that. And then they're really focused on ensuring that there's communication with patients if they have not been seen in 6 months' time. So that is looking really good as well. The business office is evaluating the billing timeliness, both hospital and professional. There's been a significant improvement since the change from change to Quadex. Diagnostic imaging monitors the recall rates of breast cancer screening and imaging, and both of those are under the national average. For example, if somebody is having a breast cancer screening, we call them back 5.5% of those people, where the national average is 9.4%, and we want that to be on the lower side. Human Resources evaluated employee engagement related to the onboarding experience, and overall satisfaction was 4.5 on a scale of 1 to 5. The emergency room department reported that telestroke services were used on all applicable patients, and the ED arrival time to provider time was 21 minutes, and then ED arrival time to triage time is also less than 3 minutes, so that's really good as well. The birthing center reported that they had no primary C-sections, which is wonderful, and then the perioperative department reported no post-op sepsis and is monitoring post-op phone calls, and then collaborating with Dr. Bowen for surgery and tissue review collaboration. We had no adverse drug events reported from the pharmacy, and then purchasing reported 100% compliance on appropriate follow-up for any recall notifications that they receive, and so they're monitoring that and tracking that very well, and had 100% follow-up, appropriate follow-up with that as well. So, and that is all I have.
Great. Thank you, Laura. Next, we'll go with Janine and the approval of the Personnel Committee report.
Thanks, Mike. The Personnel Committee met previously. We reviewed the credentialing for the month. We have 3 initial appointments, 8 reappointments, and 1 voluntary withdrawal. I would make a motion to approve this credentialing.
Okay,
I'll second that.
we have a first and a second. All in favor?
Aye.
Opposed? Same sign. Motion carries. Next, we'll go to Barry for this consideration approval of executive committee.
Back in January, when the board approved the committees, one of those committees is the executive committee. But according to our bylaws, the executive committee must include the 3 officers. And we had Janine included in that committee instead of Jan. Jan is an officer and Janine is not. So we just want to revise that and ask the board to make that one change to the committee assignments.
I'll make that motion.
Second.
Okay, we have a first and a second. All in favor?
Aye.
Opposed? Same sign. Motion carries. Barry will continue with the CEO report.
I want to just give you an update on the strategic planning sessions that we've had so far. We did do a SWOT survey analysis with each individual medical staff member and all the department managers. So we kind of started out with that. We did provide all of those responses back out to all the medical staff, as well as the department managers. And then we had our sessions. We had the medical staff last week, Tuesday morning, and we had the department managers this morning up at the Turklesons, and Terry facilitated both those sessions, and did a really, really good job with that. Had a lot of really good discussion. So we're kind of regrouping now and pulling that information together from both of those sessions. And then we will be coming back to the full board with kind of more of a compiled, kind of a compiled report of what we want that plan to look like. So basically, we're trying to update our current strategic plan from 23 to 25. It's 23 to 25 now. We want to update it for the period of 25 through 27. So that's what our goal is. And I think we'll probably be able to bring something back to the board in this summer, sometime maybe June or July timeframe. There's a little bit of work that we're going to have to do with committees and kind of really, we stayed somewhat high level in these sessions, and we're going to have to drill down a little bit to really make this worthwhile project. So that's my update on the planning sessions. I don't, Terry, if you have anything to add to that.
I just thank everybody that enriched the discussion in the sessions, and thanks to the admin team for contributing and being part of that as well. So I appreciate all medical staff and department heads that engaged with me in the last couple of sessions.
So I wanted to give you an update, or actually, it's not just an update, I need to have your approval related to the ambulance commission. Do you have a PowerPoint on that? Okay. Let's move forward. Can I move it with that? Oh, there we go. So as you know, we did do the essential service tax for back in November of '23. That was approved by the community, by the county, to move forward with essential service tax, which has provided more funding for an ambulance service, which the county has now taken that over. Effective December 1 of '23, the county is providing that service. And I can't really read that, but really the purpose of the ambulance commission was to make sure there was ambulance services in the county, and they also helped fund to make sure that that happened. With the new funding that we have, which will include, I think I have it written down here in a resolution, but again, that's really hard to read. There's the essential service tax. There is billing revenue from the ambulance service. The hospital does have a contract with the county for the county to provide transfers, facility transfers, and we're providing them $100,000 a year next year, and then I think it goes up by 5% each year after that for, I think it's a five-year agreement. And then there's also the income surtax that will happen. I think that's, I'm not sure when that gets collected, but maybe the end of this year. So there's a lot of different funding streams that are available that we didn't have before. And the county is going to be able to make that work financially. And everything that we look at indicates that is the case, that they will be in a good position financially. Clinically, I think the service itself has been very good. I have not heard any complaints about the county ambulance service. So we're at a point where, and this has kind of always been the intention since we started talking about this 2 or 3 years ago, that the ambulance commission could go away at some point. And so at the last ambulance commission meeting was a couple weeks ago. They did approve dissolving that entity. And I did have Marcus Gross involved in this, and he did think that it was important that all of the boards of each of the entities, the county, hospital, and the city, approve of that dissolution. So I am going to need a motion from the board to move forward with that and basically approve what the commission has done. Janine sits on that commission, so she was involved in that. Just a little bit more information. So the commission itself did own the 2 ambulances, and so those ambulances will be transferred over to the county. That's really been the intent all along, was once, whether it was the county, the city, the hospital, it was always the intent of the commission to turn those ambulances over to that entity that took over the ambulance service. So we will be transferring title of those ambulance here in the next 2 or 3 months. If you can read it, this was the resolution that the ambulance commission approved, essentially dissolving the ambulance commission. So I guess I would need approval from the board to move forward with that.
I move approval of the dissolution of the ambulance commission.
I'll second that.
Okay, we have a first and a second, all in favor?
Aye.
Opposed, same sign. Motion carries.
We did have got some good news here recently. We were named a top 20 hospital, critical access hospital in the nation out of 1,300 hospitals for quality. And so we were a top 20 overall hospital in 2024, but they also have 2 other awards that they give out. There's the one for quality and there's one for patient perspective. So this year we got the overall quality award. Just wanted to make sure the board was aware of that. It's really a great recognition to get, and feel like we're headed in the right direction with quality, the quality that we provide here at the hospital. So just wanted to let you know about that. I am wanting to kind of change the format of the agenda a little bit and have all of the senior admin team that come to these meetings have a kind of a standing report for them, we need to change this format a little. So I'll have each of them report when I get done here. But the other thing that we talked about was moving to possibly going to a consent agenda, which basically just means any of the non-controversial items on the agenda can be approved at the beginning with one motion. So the things that I would include in that would be the monthly bills, approval of the agenda, approval of minutes, and approval of the credentialing. So all of that could be done. You could review all of that information in advance of the meeting. And I think there's an opportunity, if there's something you do want to discuss, it can be moved down into the regular part of the agenda if you mentioned that at the beginning of the meeting or someone questions that at the beginning of the meeting, but otherwise those items would just be approved in one motion.
So would you delay the approval of them until discussion was made later on in the meeting, or can we have discussion before the approval's called?
Yeah, if you want to have discussion, then we would move it down into the regular agenda and then and talk about it at that point. It would be approved separately then. So you can let me know if we don't have to do that. Obviously, it's not done that way this month, but we're looking at maybe doing it moving forward. So you can let me know if you're okay with that. So I guess then I would turn it over to maybe Jill to give your report, and then we'll go through, have Kim and Jeff, and Christy has her own report, and then have Nicole speak as well.
Sure. So for your personnel or human resources report, we've had several department leadership changes in the last 2 months that I wanted to bring to the board's attention. Those were mostly due to retirements and promotions. So with Nicole Ollinger's promotion to our chief nursing officer, that opened up some positions in our surgery department, as well as our specialty clinic. Michelle Weiss, she's a long-term employee of Myrtue. She was promoted to our surgery and specialty clinic director position. She most recently was a nurse navigator in the department, and she also oversaw our community health department previously. So pleased to promote her into that new role. Shay Kirst Hogansey, she was hired as our surgery director. She came to us with some perioperative experience previously, and she also has knowledge of robotic assisted surgery. So we're looking forward to having her oversee that department. Mary Ford, she was just recently hired as our director in environmental services. She brings many years of EVS experience. She worked in educational institutions as well as other hospitals overseeing EVS staff. So we're looking forward to having her as well. And then Dale DeSico. Dale is our new certified dietary manager. So he replaces Tammy Stinn, who was with Myrtue for many, many years. And so he comes to us with also many years in the food service industry as head cook and as dietary manager where he previously worked. Dr. Devine already talked about Erin Soma, our newest advanced practice provider who will be joining us in May, covering our Earling Clinic. She has gotten positive reviews from staff having previously worked with us as well. And Nicole Topliff, she's going to continue to work with us while she's relocating. She's still going to help us cover weekend quick care clinic, as is Erin. So we've got a nice group of providers who will be able to provide that quick care clinic coverage. We're also in conversations with another advanced practice provider who's interested in quick care. So we're excited about that. We've interviewed that individual and looking forward to what's to come with that. And then as far as family medicine and OB recruitment, we do remain in conversations with a third-year resident who visited us just prior to the new year. We are finding that FMOBs are very difficult to recruit. They're not receiving the level of C-section training during their residency program, and because the prioritization is going to OB students and fellows. So this physician that we're in conversations with, she is also interested in a fellowship, and we're going to have that continued conversation with her this Friday. So I just shared, there's a lot of changes that have taken place in the last couple of months. Overall, however, our retention statistics are very positive. So our goal overall is to maintain a retention rate of 86% over a 12-month period. We do benchmark ourselves against other Iowa Hospital Association hospitals as well as the healthcare industry overall. And so Myrtue's retention rate is very favorable in relation to those metrics. So we continue to monitor that trend year over year, fiscal year over fiscal year. Our fiscal year is not quite ended, but as of year to date, we are at just short of 88% overall staff retention. And so we continue to monitor that as well as the turnover reasons to make sure we're addressing why people are choosing to leave as well. That's it.
I just wanted to share a few community events. Oh, do you want Nicole?
No, go ahead.
Okay. A few community events that are coming up. The first one is this Saturday. It's Kids Fest. It'll be over at the Vets from 9 to 11. Kids up to the age of 11 are welcome to come with their families and participate. Lots of different prize drawings, and also I think the first 400 kids through the door get a free little goodie bag. I can hand these flyers around if you guys would like. Then on May 13th, it's Demystifying Mental Health Care. It's an open house being held at our behavioral health space down on Morning View Drive. And it's just a time to be able to see the space and ask questions, should there be any, and be able to answer to the public if there's any questions. The third thing I'll mention is the Mental Health Action Walk. This kind of correlates right along with the Mental Health Action Day on Thursday, May 15th. This walk will be at Pioneer Park from 5:30 to 7:30. Live music, food trucks, and lots of other things, just kind of bringing people out to talk about mental health awareness. And then the last one, it is Senior Health and Fitness Day. This will be held on Thursday, May 29th. It will be over at the Peterson Family Wellness Center. This has been happening for the last few years and has actually had a tremendous turnout. Lots of different speakers. Dave Bauman from Senior Life Solutions will be there as part of presenting, as well as Katie Sandquist, one of our therapists through behavioral health. But then just a lot of other kind of open conversation. Dr. Jonk has been there in the past, and dietary has been there, and just kind of discussion in regards to health-related items and how to kind of keep the focus on preventative care as well as healthy habits and healthy behaviors. So just a few things, but lots of community opportunities and definitely good education to get out to our patient population and anybody interested.
Maybe have Jeff.
Great, yep. A few things, as Joe mentioned, Mary Ford started with EVS a month and a half ago and has a lot of pretty extensive EVS experience. She's made some very nice changes so far to the team for coverage. She has been involved in interviews and has hired 3 people. 2 started last week, 1 starts next week. So we're close to full staff. I believe we have 1 full-time opening and several on-call positions available. She and I have been working on planning for how to accommodate the new space once it's all active. IT side, the last board meeting you approved the security system. All of that equipment has arrived. We had a kickoff meeting on Friday. So the first 2 weeks of May, we will be installing the video system. And then we will be transitioning into the doors after that on a staged process. So it's not a cut and run type implementation. We're going to do it systematically and work through the issues on the first one so that the rest all will go much easier. Last I'll bring up is on the buildings, Rural Health Center, the clinic. You can see the progress is going on. The south wall, that middle section, all the brick is laid. It's looking nice. They're going to transition over to the east side of the building to start laying the brick facade there, and then to the north. Inside, about 90% of all of the studs are in place. They are finishing the rough in of plumbing and electrical. They'll then do something called a Matterport, which is a 3D rendering of each room on both of the floors. So we've got video representation of where conduit is, where the pipes are and everything. And then sheetrock's going to be going on the walls after that. Inpatient, we've already run our Matterport on the 5 rooms on the south side of the hallway, and they are putting sheetrock up, insulating and all of that, so that is progressing pretty well. The cardiac rehab project that we're doing in-house is progressing well also. It's been painted, the ceiling tiles are, majority are in, what's not in are where we need to put fire sprinklers, heads and such. That is scheduled for tomorrow and Thursday of this week. Med gas will be put in there later this week or early next week. The delay on both the inpatient and cardiac rehab and the exam rooms are flooring. The factory shut down for retooling, and they're not going to make the floor until the first week of June or last week of May. So we have worked with Murray to come up with a plan on how to accommodate that delay without affecting the overall timing. So we've got a pretty good plan there. Nicole was involved, and we think we can accommodate that pretty nicely. The flooring in inpatient and cardiac rehab also affects the timeline on the rural health clinic, but we feel we've got that accommodated for also. The biggest one would be Dr. Jonk when she moves up to practice in the hallway upstairs here. She won't have to move until the end of June, early July now. So things are moving pretty well.
Well, I think Nicole and Christy are in that next section, so I'll turn it back over to you, Mike.
All right. I think that this will be a great addition to the agenda, Barry, having these department heads and senior admin. It's a great, just to measure the progress by the department. So great, thank you very much. Now we will go to the capital purchase request by Nicole.
I tell you to throw it, but I don't think that'd go very well.
Only if you dropped it.
Yeah, that's fine.
Well, one quick update that I was gonna share before we go through this is we did do our first robotics procedure since the last board meeting. So we had staff training in the dry run with the surgeon, and now we have a few cases under our belt. So that has gone off without a hitch, and I think it went very well. The intuitive team, which is the robotics team, has done this a few times, so you could tell that they kind of had it mapped out for us. And then Dr. Kelly Anderson, she's been trained on the robot before, so early May, she's going to Chicago to do a proctored case or two, and then she'll come back here within the next week and do her first case here. So that has been blocked off, and we actually have our first case scheduled, so we're excited for that. So moving to orthopedics, we'll talk a little bit about orthopedic equipment upgrades here. So our current systems, a majority of it was purchased in 2014 when we moved down to that new space. And so the upgrades have been part of our 3-year budget since about 2024. What that means is, and as we go through this, you're gonna look like we're at a tool shop trying to figure out what we need for patients, but we need a large power system, and with that comes helmets because it's a large power system. And then we have a micro power system, a cordless power system. Our current arthroscopy pump was purchased in 2017, and most things are about a 5 to 10 if you push it your life in, as far as a surgery standpoint. And then also looking at purchasing a new shoulder set as well, which we'll go through and look at what each means here. So a large power system looks, is what is shown there. It does look like power tools like we talked about. This system is used for total hip and total knee arthroplasties along with some fractures. That is a picture of the helmets. That is what the surgeon and those that are scrubbed into the case wear during the case. Again, that's used for our total joints and our large fractures when you're using that large power system. The micro power system is, again, a power system used for smaller things though, like hand and wrist and podiatry procedures. The cordless power system is used for sports medicine and again, hand and wrist and some fractures. And then that is an arthroscopy pump. Those are used for any new scopes, shoulder scopes, or hip scopes that we might do here. And then a shoulder set right there just demonstrates some of the different items that are in a set, and it goes in that tray that's kind of at the top of the screen, and you use that entire set for a shoulder procedure. Some additional instrumentation I tried to put up there for you, some extractors, bone hooks, chisels, drivers, and pliers. Again, it's like you're at a power tool shop, but that is what we use for orthopedic cases. So when we look at the pillars here for quality, this equipment is built to be more durable for reprocessing. Obviously, it's just newer and they've learned like what might be better at this point, and so it's more durable and longer battery life. From a service standpoint, we'd be using the latest technology. For people, you'd have improved provider and team member satisfaction just with use of that latest technology, and then improved patient satisfaction, again, through the use of the latest technology. As far as a growth standpoint, we'd have the ability to offer more procedure types. Currently, when we had Dr. LaRose, we really were not doing that many procedures. We were doing a knee scope here and there, and with the hope that we have more sports medicine outreach, we'd be able to offer more shoulder procedures and knee scopes and potentially grow with like an ACL, MCL program as well. From the financial standpoint, there are some approximations up there as far as the dollar amount for the equipment. So large power, we're looking at a little over 100,000, micro power 65,000, cordless power 55.5. I won't read all the way through that because you guys can read that. There would be some freight charges, and the total that we're asking for is $325,000, and that does include or exclude service agreements, but all of that equipment comes with a 1-year warranty period, so it would be covered for that first year. Again, it has been on the budget for a while to upgrade this equipment, and so we are looking at trying to do that now in hopes of growth and providing more service line for our patients here.
I see the freight is 43,000. Does this stuff weigh quite a bit?
It's really was a guesstimate on what it was. It wasn't provided in the quote, and we kind of just went off of old quotes that we got for this type of equipment. And so I think I would hope that we can stay under that, but I feel like overall that's probably what we need to ask for to upgrade the entire orthopedic systems that we have.
Is it all one name of product, one brand, or is it
So,
multiple different vendors?
It is multiple vendors. It would be potentially Stryker, Zimmer, and Arthrex are the three main ones that we would look to go for with that. And we're kind of looking at trying to stay with Stryker for the most, because we do have an agreement with them right now where we can recycle. It's called a ProCare agreement. We can recycle our equipment. So we give them old equipment, they give us new equipment at a discounted price. So we have already established that because we use a lot of Stryker instrumentation right now.
A little different than DeWalt or your other tool.
Yeah, this, we did talk
It
about
looks
that
similar.
earlier. This would be hospital grade. So I mean, you could very much compare it to a TV that you can buy for your house, but TVs here have to be hospital grade, so.
But outside of the cost was the maintenance or what?
Yeah, the PMs and the service agreements are not included in this right now, but they would have a 1-year warranty on them, basically for any parts and labor.
And we're paying those currently, probably, the
Yes.
service agreements.
Yep.
Okay.
How much did we have budgeted last year for?
250,000 for, we were the large power and the micro power.
We do monitor how much we spend for, the board's approved $4 million for capital purchases this year. And so we did, this will be within that $4 million. So we are watching that. It might be kind of close this year because we've had a lot of unexpected things come up, but we'll still be within that $4 million budget. We take a look at those service agreements because it really is important to be able to keep our surgery going. But we do look at, what is the actual cost of the equipment versus what is the cost of the service agreement to determine whether it is reasonable and what term we want, because at some point the equipment gets old enough that it's, at some point it'd be better to buy new than it would be to continue to pay a service agreement. Because as they age, the service agreement goes up, which is understandable because their service costs go up as the equipment gets older too. OR is one area where, in outpatient services that we make a substantial amount of revenue. I couldn't tell you off the top of my head. I didn't look at that number, but if we look at any outpatient specialty provider, it's the OR, that surgery, that is making that service viable out here in the rural community. So it is important that we invest in the equipment so that they can provide those services here locally.
The new contract for orthopedic services that you were discussing earlier, they're aware of this upgrade too? So that they're going to promote in-house service?
A lot of discussion with MD West 1. In fact, we talked with them yesterday. So, yeah, they
promote in.
And our current orthopedic providers are also going to use this. It's an upgrade for them as well, and it's all things that all of the orthopedic physicians would utilize.
Good.
What's the shelf life, 5 years?
I think most things in surgery are about 5 to 10 years. Sometimes you can push things. It's very similar to like diagnostic imaging and all of that equipment as well.
I'll make a motion to approve the 329,000.
I'll second that motion.
Okay, we have a first and a second. All in favor?
Aye.
Opposed? Same sign. Motion carries. Thank you, Nicole. All right. Next, we'll have Christie, and we're going to talk a little bit about the $10 million hospital revenue capital loan and the tax exemption certificate.
Yeah, so previously we had had a public hearing to approve not to exceed tax financing for no more than $12.5 million for the rural health clinic and hospital projects. We are anticipating that it will not exceed $10 million. So that's what we're moving forward with $10 million. If for some unforeseen reason there is a lot of changes in the project, we do have that ability to offer the other $2.5 million up for financing, but there are some I call it tax exempt rules that if we can only go up to $10 million every 12 months. So we're going to leave it at that, and that's what we're anticipating we need. So we have discussed it with the local bank. Shelby County and Mid-States are kind of, Mid-States is kind of the leader in it, but they're the two big partners in coming up with the $10 million for the project, for the debt. Defiant State Bank and Farmers Trust is also participating in it, so it's the four of those entities. They came back with 5.9% interest rate on it, which we were happy with. When we originally started talking, there was some talk of 7.5 up in that area, and we were hoping to get 6, but they came with 5.9, so that is great. We're expecting the first drawdowns on that note in June of 2025 here. Currently, we're using our excess funding that we have wrapped up in CDs that are maturing at intervals so that we can meet those payment apps for our construction project. The first payment would not be anticipated to be due until March of 2026, which may or may not. First payment will be due then, so we'll have all the draws, but we might not be fully closed out of the project. It just takes a little time, and if things get delayed there, if there's any kind of construction delays, that may change. So we would need to have a resolution to approve the tax exempt certificate, which for the $10 million, and then a resolution to approve and authorize the form of the loan agreement and authorizing providing the issuance of the not to exceed $10 million hospital revenue capital loan note, Series 2025, and providing for the method of payment for said notes, which is our revenue, so they're revenue notes, so there's no tax asking to cover this. The tax exemption comes from the fact that the bank gets some tax breaks on their end for issuing these type of debts to us. And in those, and also in that resolution, basically, we will be setting up another bank account. The bonds, because they are tax exempt, are required to go into, if we take a draw, it goes into a project account, and then we transfer it from that project account into our regular checking account when we make the loan payments. That way it's not commingled with all the other general funds of the hospital until such time as we actually need to make that payment. So there'll be any questions on those notes or?
All right,
Going
yeah.
to abstain from the vote. Do a conflict of interest with the bank.
I'll make a motion to approve what Christie just said.
Okay, what we're approving is a resolution approving and authorizing a form of loan agreement and authorizing and providing for the issuance and securing the payment of not to exceed $10 million in hospital revenue capital loan notes, Series 2025 of Shelby County, Chris A. Myrtue Memorial Hospital, under the provisions of the Code of Iowa and providing a method of payment of said notes. So that's what we're approving. We have a first. Can I get a second?
Second.
First and a second, all in favor?
Aye.
Opposed?
Due to conflict of interest.
Opposed, same sign. Motion carries. All right, thank you. Do we need to, that was also for the consideration of the tax exemption certificate, right, Christie?
Yep.
That was
Yep.
also for that resolution. All right, now we'll go to the monthly financial statements by Christie.
Okay, well, I'll do my little administrative report first here. So I am currently going through the process of meeting with every department manager. We talk about, for budget purposes, to talk about revenues, anticipated increases in services, the needs of their departments when it comes to, we go through the capital expenditures that they're anticipating with for the next 3 years. If they've got minor equipment, which is anything under $5,000 that we need to purchase, we go through their entire budget for staffing, and if there's any needs for additional staffing, those type of things. We will bring that operating budget to the board in June. and approve. That will be for fiscal year starting July 1 of 2025. And prior to that, we'll meet with the budgeting and finance committee to go into detail about that. We anticipate what we might be giving for increases in January, and looking at all that, the budget with that committee and bringing that to the board in June. We are looking at project Barry has approved, and we have reviewed from a purchasing and construction and maintenance, looking at project management software. We do have a module within our current accounting software, so it'd be minimal expense to add to our budget each year. There'll be some upfront costs, but we'll use it to, really break down the internal projects that we're working on, any kind of major, like if we do a surgical suite or we do a surgical piece of equipment that has multiple different vendors and stuff. That way it really ties into being able to put the budget in there, having very readily access to look at, are we staying within that budget? And we can break it down into multiple different, carpet, flooring, wall covering, ceiling, those type of things, which will ultimately help the maintenance team look at future projects and being able to put together budgets for those. So we really think that will be advantageous to maintain the projects that we have going and within budget, and being able to easily review those projects. So as soon as something is, put a requisition in for it or a purchase order in it, it records it within that project management, and we can go in on a real-time basis and say, this is how much we have left to spend, this is how much we've spent in this area. So we're going to work on putting that together and getting that implemented. So
It looks like what you've handed out here is a little more up to date than what's on the screen. That's reflecting February, or?
We haven't gone over February because we didn't have a board meeting, and so we've got February and March to both discuss here.
Right.
Yep. So in February, that was the 8 months ended in February 2025, and we could do that comparison to February 29th of 2024. So as you can see there, and we just continue to grow in our outpatient visits. So if you compare the year to date, which is 8 months here in February, it was 5.4% increase. So we're up to over 40,000 patient visits for outpatient services at the end of February of this year, compared to 38,000 last year. ER visits, we are staying pretty consistent. For year to date, we were at 3856 and we were at 3866 the previous year. So not seeing the influx that we had thought maybe we would have with the new ER, but that's good too. We don't want patients to use ER services when they don't have to, so that's good.
I guess the urgent care is picking up quite a bit of that.
I was just going to say that the weekend clinics.
That weekend
Probably.
clinic that's
Yep.
what we're hearing. A lot of people from the public are using those services and are thankful that it's there versus having to go to the ER.
Yep.
So we're hearing good things about your services on the weekend coverage.
And the outpatient increase, can we tell if that's more of a local thing, or are we reaching out, or are they coming in from outside the area, or are they more users inside?
We haven't really looked at where they come from zip code purposes on the outpatient clinic, but we can sure look at that we can get reports out of Epic based on zip code. We do that, like at behavioral health, to, when we're looking for having such a backlog at behavioral health, we look at, where are our patients coming from? Are we serving our community? And then reaching out to other communities secondly. But we can sure look at that from an outpatient perspective too. Surgical procedures, we've had a change in surgical staff, our surgeons, so we'll likely see that. And I think in March we have seen that go up a little bit. So we were down, we do about 100 a month in February of 2025. Last year in February did 140. So we're at 907 for the year compared to 979. Physician clinic visits, which is our rural health clinic, includes visits just for, that they come in and see the coag nurse, any kind of vaccines, those type of things, plus what they're seeing are providers. So we are up 5.5% at the end of February there at 29,795 for the year to date. Behavioral health, we are running a little bit behind. We've had some staffing changeover, so it's difficult to recruit therapists, but we are continuing to see that increase. In March, we'll see that. Our average daily census in February was up quite a bit in February, and that was for observation patients there, so we were up again in February. But year-to-date, we are still down 9.2%. We just don't, it's difficult to get patients in the hospital, so that does basically go to the fact that we are treating more acute and sick patients in our outpatient and in our RHC clinic. So you can see that insurance companies are driving them to do the clinical setting versus the inpatient setting. We had 10 births in February. We are up to 76 at the end of February 2025 compared to 53 last year. So really seeing a good increase in that OB services that we are offering and patients taking advantage of that. We are up 12.8% in our operating revenue, up 7.7% in operating expenditures, and we are up 39.7% in our non-operating. So really have tried to do a lot more investing, and we are getting some better rate of returns. We'll see that go down as we use up those funds to do capital projects. But we are sitting at the end of February for the 8 months at $3.9 million in net income compared to 1.5 last year. You know, again, a big portion of that is our Medicaid directed payments. We are cautious with those with the current administration that hopefully those won't go away. IHA is really reaching out to their constituents in different states and hopefully keeping that alive because it is a substantial benefit to the hospital. And it is meant to just try and get our Medicaid payments, which hadn't been increased for over 10, 15 years, getting them closer to what we're getting paid for commercial plans. So it was lagging behind. So, yeah, I think you have this in your packet. I did give out, that's the 4-year comparison, so you can see there how we've increased in most areas over the last 4 years. You have the March. Yep. So March, we've just finished up. It's the 9 months ended, and again, you can see we're at 5.2% increase in outpatient visits. We were over 5,000 in the month of March, which is a really busy month. 45,600 for year-to-date of visits of patients coming in for outpatient services, which includes lab, digital imaging, outpatient specialty, surgical clinic, all of those different outpatient areas. PT across the street. So emergency room visits at this point at the end of March, we did have a busier March, so we are up 0.6% to 1,000. 4,334 this year compared to 4,310. So we're holding our own there in emergency room visits. Surgical procedures, we're at 1,000 this year compared to 1,119 last year. But you can see we've made up some of that difference. Dr. Garden's here now, and patients are seeing him. The physician's clinic, we were up in March to 3,866 compared to 3,400 last year. So we are up 4.6% in our physician clinic visits this year compared to last year. Behavioral health, we're still, like I had said, we are filling staffing positions. It does take them a little bit to get their clientele built up and to learn our systems. You can see there we are at our average daily census and for observation, swing bed, and acute patients was 8.25 per day in February this year compared to in March of this year compared to 6.5 last year. We are at 7.42 on average daily census and on the med-surg floor compared to 7.88 last year. OB patients, we had 10 again in 10 babies in March. So we're up to 86 compared to 59 last year. So again, continuing to see that. Hopefully, we are scheduled to be, I believe it's 116 is what she's estimating for this fiscal year. So we're going to be busy the next 3 months after March. So we had, year-to-date, we had $46.8 million in operating revenues, $44.2 million in operating expenses, $2.6 in operating gains, $1.7 million in operating, non-operating income. And so we're at 4.3, almost 4.4 million in net operating income from all sources, which is about 50% higher than we were last year. 4-year compare we have up there, and again, like, you know, you can see there in outpatient how we've just continued to go up in the last 4 years, stayed really consistent in ER visits, surgical procedures. We have a little bit of dip there in this year, but we've had change in surgeons, so I anticipate that going up. Physician clinic visits, we did have a spike there in 2022, which is really pandemic-related increase there. We are up from the other 2 years since the pandemic. Outpatient behavioral health there will continue to climb there as we fill those positions and move to the new facility. Average daily census, we've been at 10 in 2022, down to 7.42, which is across the board industry. Every facility is seeing those inpatient stays go down. Births, you can see there we are up highest we've been in the last 4 years, and again, we are up the highest we've been in 4 years in our net income there too. Any questions on the financial reports?
I'll make a motion to approve.
Second.
We have a first and a second, all in favor?
Aye.
Opposed, same sign. Motion carries. Payroll and claims by Christie. If there was any questions or
We
you have
haven't had any
anything?
questions brought up, so.
I'll move the approval of the February and March 25 payroll and claims.
Second.
And we got a first and a second. All in favor?
Aye.
Opposed, same sign. Motion carries. Any other words, Barry? Would like to? We good? Anybody else? If not, we're gonna go ahead and call an adjournment. If I get a motion. Move. Got a first
I'll second.
and a second. All in favor?
Kate.
Opposed, same sign.
Guilty.
Put your hand.